Hello, this is Dr. Jichao Liu. Today I'm going to talk about a guideline for evidence-based treatments for couples with unexplained infertility. This guideline was released by Practice Committee of American Society of Reproductive Medicine. This guideline is published in Fertility and Sterility 2020 February issue. The objective of this guideline is to provide evidence-based recommendations to practice physicians and others regarding the effectiveness and safety of therapies for unexplained infertility. ASRM conducted a literature search which included systematic reviews, meta-analysis, randomized controlled trials, and prospective and retrospective comparative observational studies published from 1968 through 2019. The outcomes of interest included the birth rate, clinical pregnancy rate, implantation rate, fertilization rate, multiple pregnancy rate, dose of treatment, rate of ovarian hyperstimulation, abortion rate, and ectopic pregnancy rate. Among the couples experiencing infertility, up to 30% are diagnosed with unexplained infertility. In unexplained infertility, the female partner should have at least one patent fallopian tube and documentation of ovulation. For the male partner, his semen analysis should show adequate number of motile sperm. The treatment includes timed intercourse, IUI, and IVF. Ovarian stimulation is used in timed intercourse, IUI, and IVF quite often. It intends to induce development of multiple mature ovarian follicles. It's also previously described as superovulation, ovarian hyperstimulation, and controlled ovarian hyperstimulation. It can be managed with oral medication, such as clomiphene and letrozole, or injectable gonadotropin. It's different from ovulation induction, which referred to the pharmacological treatment of an ovulatory woman to induce ovulation. Now look at the data on timed intercourse for the treatment of unexplained infertility. There's good evidence that clomiphene citrate with timed intercourse is no more effective than expectant management. There's also good evidence that letrozole with timed intercourse is no more effective than clomiphene citrate with timed intercourse or expectant management in the treatment of unexplained infertility. Please note, letrozole is off-label used in infertility treatment because animal studies have shown that letrozole can cause birth defects if taken during pregnancy. FDA released warnings for its usage in pregnancy, but there's evidence to support its safety when used to induce ovulation or ovarian stimulation. There's insufficient evidence that gonadotropins with timed intercourse is superior to expected management in the treatment of unexplained infertility, and there is moderate evidence that the treatment outcomes with gonadotropins are similar to oral medications in timed intercourse cycles. Most studies report no difference in pregnancy outcomes comparing gonadotropins to ovarian stimulation with oral agents or higher pregnancy rates at the expense of increased risk of multiple gestation pregnancy. Difference in outcomes between investigations are likely due to different patient populations, dosing, and cancellation criteria. The treatment of unexplained infertility by timed intercourse is not recommended. Now let's look at the data of IUI on the treatment of unexplained infertility. There's strong evidence that IUI in unstimulated cycle is less effective than ovarian stimulation with IUI and is not significantly more effective than expectant management. There's strong evidence that clomiphene citrate with IUI is superior to expectant management and nitrous cycle IUI for the outcome of live birth rate in couples with unexplained infertility, multiple gestation pregnancy rates with clomiphene citrate with IUI treatment range from 0 to 12.5%. Difference in multiple gestation outcomes between investigations are likely due to different patient population, dosing, and cancellation criteria. There's strong evidence that there is no significant difference in pregnancy rate or multiple gestational pregnancy rate following letrozole with IUI as compared to clomiphene citrate with IUI. Both are superior to expectant management and natural cycle IUI. There's insufficient evidence that the treatment with low-dose gonadotropin with IUI is associated with higher pregnancy rate than clomiphene citrate or letrozole with IUI. Difference in the outcomes of these trials may be due to different dosing protocol, patient populations, and cancellation criteria. In couples with unexplained infertility who had a good or intermediate prognosis for unassisted conception, there's fair evidence that the treatment with low-dose gonadotropins with IUI is no more effective than 6 months of expectant management. There's no difference in multiple pregnancy rate between clomiphene citrate or letrozole with IUI treatments compared to low-dose gonadotropin with IUI. There is insufficient evidence that treatment with conventional dose gonadotropins with IUI is associated with a higher pregnancy rate rather than clomiphene citrate or letrozole with IUI based on mixed findings from well-designed studies. Treatment with conventional dose gonadotropins with IUI demonstrate either no difference in pregnancy outcomes with similar multiple gestation pregnancy rate compared to oral stimulation with clomiphene citrate or letrozole with IUI, or higher pregnancy rates associated with a higher rate of multiple gestation pregnancy. Difference in both outcomes between investigations are likely due to different patient populations, dosing, and cancellation criteria. There is good evidence that clinical pregnancy and live birth rate are similar when comparing letrozole and low-dose gonadotropin with IUI versus clomiphene citrate and low-dose gonadotropins with IUI. There's fair evidence that clomiphene citrate and conventional dose gonadotropin with IUI treatments are associated with higher pregnancy rates than expected management. There's good evidence that clomiphene citrate with conventional dose gonadotropins with IUI treatments are associated with an increased risk of multiple gestation pregnancy. There's fair evidence that the timing of IUI relative to ICG injection between 0 and 36 hours does not impact pregnancy rate in ovarian stimulation with IUI treatment. There's fair evidence that the live birth rate following a single IUI is not significantly different than double IUI in treatment cycle with clomiphene citrate. There's insufficient evidence that ultrasound monitoring for timing of IUI improves pregnancy outcomes compared to urine LH monitoring in clomiphene citrate IUI treatment cycle. Due to steady improvements in IVF technology over the past 2 decades, IVF has become the most effective form of treatment for nearly all causes of infertility, but is substantially more invasive and more costly than other methods of treatment. Current evidence does not support IVF as a first-line therapy for unexplained infertility or expectant management for 6 months, or a limited course of treatment of ovarian stimulation with IUI in women less than 38 years of age. However, it is important to note that many of the included studies were conducted in an era of lower IVF success rates than those currently observed. There's also good evidence that immediate IVF in women at 38 or more than 38 years of age may be associated with a higher pregnancy rate and a shorter time to pregnancy as compared to a strategy consisting of overstimulation with IUI treatments with either oral medications or gonadotropins prior to IVF. There's good evidence that in couples who fail to achieve a pregnancy following a course of clomiphene citrate with IUI treatment, immediate IVF results in a shorter time to pregnancy and a lower cost pregnancy than a strategy that incorporates gonadotropins with IUI treatments in women younger than 40-year-old. There's good evidence that there is no reported difference in clinical pregnancy and live birth rates when comparing IVF with conventional fertilization to IVF with ICSI in the setting of unexplained infertility. However, ICSI has been associated with higher fertilization rates and a reduced risk of complete fertilization failure as compared to conventional fertilization. Now let me make a summary. Let's see what's not recommended first. It's not recommended to perform IUI in natural cycle for the treatment of unexplained infertility because it's less effective than oral ovarian stimulation with IUI and likely no more effective than expectant management. It's not recommended to use clomiphene citrate with time intercourse as a treatment for unexplained infertility, as it is no more effective than expectant management. It's not recommended to use letrozole with time intercourse as a treatment for unexplained infertility, as it is no more effective than expectant management. It's also not recommended to use gonadotropin with time intercourse in the treatment of unexplained infertility. Studies report either no difference in pregnancy outcomes compared to ovarian stimulation with oral agents or higher pregnancy risk associated with a higher risk of multiple gestation pregnancy. It's not recommended to use letrozole or clomiphene citrate plus conventional dose gonadotropins with IUI, as most studies associated with improved pregnancy rate over overstimulation IUI with oral medications are associated with an increased risk of multiple gestation pregnancy. It's not recommended to use low-dose gonadotropins with IUI in the treatment of unexplained infertility, as it is more complex and expensive, and likely no more effective than overstimulation with oral medications with IUI. It's not recommended to use conventional dose gonadotropins with IUI, as most studies associated with improved pregnancy rate over overstimulation IUI with oral medications are also associated with a higher multiple gestation rate. Now let's see what is recommended for the treatment of unexplained infertility. It's recommended to use clomiphene citrate with IUI in the treatment of couples with unexplained infertility. It is recommended that letrozole with IUI treatments be considered as an alternative regimen for couples with unexplained infertility, as studies to date suggest similar efficacy. Of note, letrozole is not FDA approved for treatment of unexplained infertility, but is considered an effective and well-tolerated option. It is recommended that single IUI be performed between 0 and 36 hours relative to ICG injection in overstimulation with IUI treatment. It's recommended that couples with unexplained infertility initially undergo a course of overstimulation and IUI with oral agents. For those unsuccessful with oral overstimulation and IUI treatments with oral agents, IVI is recommended rather than overstimulation and IUI with gonadotropin. The above information represents my personal explanation to the committee opinion. They are for medical education to the public. If you have any specific medical question, please get medical advice from your physician. If you like the above video, please subscribe, share, and leave your comments. Thank you.